What's up, guys? Today we're going to talk about epistaxis. We're going to go over the epidemiology, anatomy, etiology, patient presentation, physical exam, and management. So with that said, let's dive right in and talk about epistaxis. Epistaxis is a common complaint that occurs in up to 60% of the general population. So no matter what field of medicine you're in, you're likely going to run across one of these patients on numerous occasions. Epistaxis has a bimodal age distribution, with most cases occurring before age 10 and then peaking in occurrence once more in patients 45 to 65 years of age. A seasonal variation is also seen, with the predominance of nosebleeds happening more frequently in winter months. Now, before we go on, let's briefly talk about some anatomy of the nose. Epistaxis can be broken down into anterior and posterior bleeds. Anterior bleeds make up the majority of these cases and account for about 90%. The most common origin of anterior bleeds occur in the Kisselbox plexus. Three primary blood vessels anastomosis into this region and are as follows: the septal branch of the anterior ethmoid artery, the lateral branch of the sphenopalatine artery, and the septal branch of the facial artery. While posterior nosebleeds most commonly arise from two vessels and are from the posterior lateral branches of the sphenopalatine artery, or they can arise from the internal carotid artery. So now that we know what arteries are commonly involved, what are the most common causes of anterior nosebleeds? Anterior nosebleeds most commonly result from mucosal trauma or irritation. You can remember these causes by the mnemonic forward, that's FORWARD. F stands for facial trauma, often from a motor vehicle collision or other blunt facial trauma. O stands for anticoagulation. R stands for chronic excoriations that can lead to septal perforation, such as a persistent cocaine abuse. W stands for wetness, or lack of, such as low moisture environments that cause mucosal dryness and irritation. A stands for arterial mucosal hyperemia, as seen in allergic or viral rhinitis, can make bleeding from local trauma more profound. And R stands for retained foreign body, and maybe it has eroded through the artery from some direct pressure. And D stands for digital trauma from nose picking. Anterior and posterior causes can also be caused by numerous other etiologies. You can remember these causes by the mnemonic epistaxis, that's EPISTAXIS, where E stands for ETOH or alcohol abuse, P stands for platelet dysfunction or disorders possibly secondary to long-term aspirin use, or maybe they have an underlying von Willebrand disease or hemophilia. I stands for intranasal corticosteroids. S stands for suspect other diseases such as Osler-Weber-Rendu disease. T stands for tumors. Nasal cancers associated with epistaxis include squamous cell carcinoma, adenoid cystic carcinoma, melanoma, and inverted papilloma. A stands for aneurysm. So maybe there's a massive hemorrhage from an aneurysm from the internal carotid artery. X stands for factor Xa inhibitors or other anticoagulations like warfarin. I stands for increased blood pressure, although this association is highly controversial. And S stands for systolic or diastolic congestive heart failure. So now we know the different etiologies of epistaxis. Let's briefly talk about how to take a good HPI in these patients. As with all patients, take a look at the triage note and review the vital signs. Once you enter the room, your initial evaluation of the patient should focus on the ABCs of emergency medicine. Make sure they are protecting their airway, speaking in full sentences, and are cardiovascularly stable. In these patients, make sure to note when their bleeding occurred, frequency, duration, and severity of blood loss. For example, is this an isolated episode, or have they been having multiple over the past days or weeks? Ask them about any associated symptoms like recent upper respiratory infections or allergies. Take a good past medical history, asking them about any pre-existing conditions that predispose them to bleeding, to include nasal cancers, coagulation disorders such as von Willebrand's disease, recent trauma, cirrhosis, congestive heart failure, HIV. In addition, make sure to ask them about any medical problems that could be exacerbated by significant blood loss, such as coronary artery disease or COPD, and make sure they're not having related symptoms of chest pain secondary to demand ischemia, shortness of breath, or lightheadedness. Ask them about their past surgical history. Did they just have a recent nasal surgery? Are they taking any medications that predispose them to bleeding, such as aspirin, warfarin, factor Xa inhibitors, inhaled corticosteroids, to name a few? Do they have a family history of any bleeding disorders? And ask them about their social history. Do they frequently use cocaine or significantly abuse alcohol? Next, you're going to want to do a good physical exam. As I mentioned before, it is important to note the general appearance of the patient the moment you enter the room. Make sure they are protecting their airway and look for signs of poor perfusion that could indicate hypovolemia. This assessment is going to be particularly important in the elderly because these patients will have less reserve. Do they have any ominous signs of underlying coagulopathy, such as a congenital or medication-induced ecchymosis that they just attribute to sensitive skin? Do they have any telangiectasia of the skin, buccal mucosa, lips, tongue, fingertips that could signify Osler-Weber-Rendu disease? that you can see at the bedside without doing a detailed skin exam. Next, you're going to want to do a detailed nasal exam. However, before you go sticking otoscope speculums, nasal speculums, and any other tools up your arsenal in the nose, you're going to want to pre-treat them with some nasal anesthesia. The reason being is because this exam can be very uncomfortable for the patient. You can achieve adequate anesthesia with numerous different medications and methods. One option is to obtain 2 cotton balls and soak them in 2% lidocaine without epi, or 1% lidocaine with epi, which brings the added benefit of vasoconstriction. You could use a 20% benzocaine spray, also known as hurricane spray, commonly used for the pre-treatment of nasogastric insertion. You could also consider using 4% cocaine, but in this event your emergency room would probably become pretty popular. If you choose to go with cotton balls, you're going to want to soak these medications in either 2% lidocaine without epi or 1% lidocaine with epi as mentioned before. Have the patient blow their nose to remove all blood and clots. Then you're going to want to place the cotton ball directly posterior, and then the next posterior and superiorly. If you choose to use lidocaine without epi, you might want to consider soaking the cotton ball with a little bit of oxymetazoline, also known as Afrin. If you choose to use hurricane spray, you can spray this into their affected nair for about 1 second. Wait a while for the medication to take effect in their nose and take a look at the patient's fingernails. We are all guilty of nose picking at some point, but patients will be embarrassed to admit this most of the time. Look underneath the fingernails for any evidence of dried blood that could indicate digital trauma as the cause. Next, look at their posterior pharynx, making sure there's no large clots they could aspirate. If you identify a clot in the back of the posterior pharynx, have the patient first try and cough it up on their own. If this event is unsuccessful, you're going to need to remove it with suction. The reason being is because these clots have the potential to be fatal if aspirated. This task can prove to be challenging, and it will be uncomfortable for your patient. So while you're setting up suction, have your nurse get some anesthesia. I typically spray a 20% benzocaine spray, also known as hurricane spray, in the back of their posterior pharynx for about 1 second. Then using the Yonker suction, suck out any large clots. Once the patient's nostrils are numb with your cotton balls, remove the cotton balls and have the patient blow out any more clots, or you can consider suctioning them with the Yonker. But keep in mind this may be too big to fit in some of your patient's noses. Having the proper equipment will allow for an easier examination. Many ED departments have entire nasal kits just for epistaxis. Make sure you have a good light source such as a headlamp. Then properly position the patient by bringing the head of the bed to an upright position. An emesis patient should already be placed in his lap so that he can cough up any large clots and to collect blood loss. Next, have the patient look directly ahead and ask him to get in the sniffing position. Insert the nasal speculum. First look in the area of Kisselbach's plexus, because as I mentioned before, most of your bleeds will be from this origin. Look closely for the source of active bleeding and look for ulcerations or erosions. Look at the turbinates and the septum for sources of bleeding as well. Now it's not uncommon to not be able to locate the source of bleeding. In this event, maybe that's because the source is more posterior. So then how do we distinguish anterior versus posterior bleeds? Well, one technique is to place bilateral anterior nasal ribbon packing and then examine the patient. If they're having a brisk rebleeding despite proper packing, this strongly suggests a posterior bleed. Other indications of a posterior bleed could be if the patient has been sitting in the upright position and slightly leaning forward, yet you are still seeing bright red blood in the back of their posterior pharynx. This is because more proximal sources will allow retrograde flow to the oropharynx or contralateral nair, but you cannot always rely on this finding. So what lab tests do we need to order, and how do we treat these patients? So I think it's reasonable to approach nosebleeds in a stepwise approach. Initial treatment in all patients should begin with direct pressure and vasoconstrictors. So in my typical patients, even before I enter the room, I order Afrin and speak with the nurse taking care of the patient. I tell them to instruct the patient to blow out all clots, spray Afrin into the affected nose, and apply direct pressure to the ala, just below the nasal bone, for about 10 to 15 minutes. I also instruct them to position the patient so that they are sitting up and slightly bending forward to avoid from swallowing or aspirating blood. I also order an emesis basin too and have them place it in their lap so that they can cough up any large clots and to collect blood loss so I can adequately assess blood loss later. Many times these simple measures will stop the bleeding before you even enter the room. Anesthetize the nose with your agent of choice and evaluate the nose. If the source of bleeding cannot be identified, simply monitor the patient in the ED for 30 to 60 minutes, and if they're not having any rebleed, you can discharge them safely home with the prescription of mupirocin ointment to apply to the nasal mucosa 3 times a day for 3 days. Instruct them to apply it either with a cotton ball tip gently or with their finger. However, what if in these type of patients you identify the source of bleeding and it's still slightly bleeding? Well, now you're going to need to cauterize the vessel. This can be done after anesthesia is obtained with either a chemical or electrocautery. However, your ED is typically not going to have the right electrocautery devices, and this procedure can be very painful and is really only done by ENTs. So once you have identified the vessel, the use of chemical cautery is reasonable with silver nitrate sticks. However, silver nitrate will only work on a relatively bloodless surface, so this is only the next best option in those patients that have stopped bleeding or are only bleeding just a little bit. Begin by placing the applicator stick over the proximal portion of the bleed and moving towards the center, applying a small amount of pressure until a gray eschar is formed. Do not cauterize an area for more than 10 seconds. Avoid cauterizing large areas and remove any excess silver nitrate with cotton ball swabs. Be very careful when cauterizing the septum, which could lead to perforation or ulceration, and you really should never cauterize both septums because you risk tissue necrosis. Monitor these patients for 30 to 60 minutes after the procedure, making sure they don't rebleed as well, and then send them home with a prescription of Bactroban, also known as mupirocin, to use 3 times a day for 3 days. But what type of management is best for the patient who has an anterior bleed despite direct pressure, Afrin, and silver nitrate, who has a rebleed in the ED? Or maybe you never identified the source and cauterized it, but you're fairly sure this is an anterior bleed. Well, in these patients, you have a few options. You can achieve hemostasis with a Mercel tampon, ribbon gauze packing, or nasal balloon catheters. However, I find the gauze packing to be more time consuming and requires more skill than other methods, so it's not one of my favorite options. I think a reasonable option in these patients is to use either a Mercel tampon or a rapid rhino. The Mercel tampon should be applied after the patient blows out all clots and is properly anesthetized. Place the patient in the proper position with the head of the bed vertical and their head in the sniffing position. Make sure to tell the patient that although they have been anesthetized, this will still be very uncomfortable. If your patient is extremely nervous or has low pain tolerance, you may want to pre-treat them with IV opioids or benzodiazepines. Coat the Mercel tampon with bacitracin ointment. This will help to slide in easier and possibly decrease the occurrence of toxic shock syndrome. Insert the nasal tampon directly along the floor in a horizontal fashion until almost the entire tampon is within the nasal cavity. Do not put it in vertically. Next, you can expand the nasal tampon with infusing 10 cc's of sterile normal saline using a syringe, but I personally find it to be more effective to expand the Mercel tamping with Afrin. Monitor the patient for 30 to 60 minutes, and if hemostasis is achieved, have these patients follow up with ENT in 24 to 48 hours. Give them strict follow-up precautions to represent back to the ED if bleeding reoccurs and cannot be stopped with simple direct pressure. Now, the million-dollar question. Do you need to prescribe antibiotics to these patients to prevent toxic shock syndrome? Well, this topic is controversial. Toxic shock syndrome only occurs in about 16 patients per 100,000, so there's no great studies to evaluate how effective antibiotics are at reducing toxic shock syndrome. Nevertheless, I believe it to be common practice to prescribe a short course of antibiotics with staphylococcal coverage, such as amoxicillin clavulanic acid or second-generation cephalosporin, for 3 to 5 days, especially in those patients at higher risk for infections such as diabetics, elderly, and immunosuppressed patients. However, if you are an ENT out there, I would love to hear your thoughts on this. Either leave a comment on the YouTube or email me directly. Tracking back to the patient who, despite direct pressure, vasoconstrictors, and maybe even cauterization, they continue to bleed. You can either use a Mercel tampon, as we just spoke about, for an anterior bleed, but what if the patient is showing signs of a posterior bleed, such as copious amounts of blood in their posterior pharynx, bleeding from both nares, or quickly rebleeding after an anterior gauze packing? Well, in these patients, you have a couple options. Posterior bleeds can be best managed with a rapid rhino, a 10 to 14 French Foley catheter, or balloon catheter such as the Epistat. Now, I'm not getting paid by any companies to endorse these products, but I think the easiest device to use for posterior packing is most likely the Rapid Rhino. However, make sure to use the 7.5 centimeter in length Rapid Rhino. I'm also curious to hear from our ENTs out there. What type of posterior packings do you prefer from your ED providers to use? The Rapid Rhino is a balloon catheter encased with a carboxymethylated cellulose mesh. Upon contact with blood, it acts to promote thrombosis. You can insert the Rapid Rhino in the following fashion. Make sure to position the patient properly, provide adequate anesthesia, and maybe even pre-treat the patient with IV opioids or benzos. Soak the catheter in sterile water for 30 seconds. Do not apply lubricants or bacitracin, which will impair its thrombotic effect. Insert the Rapid Rhino by sliding it across the floor of the nasal cavity until the proximal ring lies within the nair. Inflate the catheter with air using a 20 milliliter syringe. The balloon catheter will conform to the patient's own nasal anatomy. With this said, there is no magic number of air to administer. Stop inflating air when the pilot cuff is round and firm. Re-examine your patient in 10 to 15 minutes to reassess if you need to put in more air. If the pilot cuff is no longer round and firm, insert more air until it is. Then tape the cuff to the patient's cheek. Monitor the patient for 30 to 60 minutes, looking in the back of their throat for any signs of active bleeding. Are they still coughing up clots? Is blood still oozing from their nose? Do they have any underlying COPD? And are they becoming hypoxic? If their oxygen saturations are dropping below 94%, you can give them supplemental oxygen via a nasal cannula at 2 liters to start and place it over their mouth. Before you discharge these COPD patients home, make sure they do not become hypoxic on room air once again. You may even want to consider having the nurse walk the patient to make sure they do not significantly desaturate. If they are still hypoxic, it would be reasonable to admit this patient overnight if they do not have home oxygen. However, if the bleeding has stopped and they are not hypoxic, send them home with the same follow-up precautions as before. Consider prescribing antibiotics and have them follow up with an ENT in 24 to 48 hours. But what do you do in those patients who, despite direct pressure, vasoconstrictors, cauterization, a good posterior packing, who are on oral anticoagulation, yet continue to have bright red blood seen in their posterior pharynx or oozing of blood from their anterior packing? Well, in these patients, you want to order some basic anticoagulation profiles to include PT, PTT, and INR. You'll also want to add in a CBC, CMP to look at their hemoglobin, hematocrit, and liver function. Compare these values to any old lab values, making sure they don't have any substantial decrease in their blood volume. In addition, if your patient presents hypotensive, altered, with signs of poor perfusion, order a type and cross early because they may need a blood transfusion later. So in these patients, you now have a couple of options. You can pack the contralateral nair with your posterior packing of choice. This will provide a counterforce to help provide hemostasis. But before you do this, I think it is reasonable to call your ENT to discuss the patient first. Depending on the severity of bleeding, he may want to take the patient to the OR and cauterize the vessel or place his own packing of choice. If there's no emergent need for his assistance, go ahead and pack the contralateral nair. Keep in mind that this may not be the best option for those hypoxic patients. Bilateral packing also increases the risk of aspiration and septal necrosis to a small degree. You will want to stop all anticoagulation medicines and correct any supratherapeutic INRs caused by warfarin. For example, let's say you have a patient on warfarin for chronic atrial fibrillation and their INR is 8. Well, even with the best posterior packing, you will likely not be able to achieve hemostasis until the INR is corrected. However, keep in mind the potential consequences of correcting the INR too rapidly or below the ideal range. For example, last month I had a patient with a nosebleed that just wouldn't stop, despite a good posterior packing. He was placed on warfarin because he suffered his first stroke 2 months prior, secondary to atrial fibrillation, and then had another transient ischemic attack 2 weeks prior to his presentation in the ED. In these patients, you need to be very careful in correcting their INR too quickly. Call up their cardiologist and have a detailed conversation about the risks versus benefits of giving them vitamin K. You should also consult your local ENT and have them evaluate the patient to consider other options. Once you decide on anticoagulation, unfortunately, there are no great studies with strict dosing protocols on the amount of anticoagulation that should be given. You can consider giving IV or PO vitamin K in your patients with mild to moderate bleeding despite packing. If the patient's INR is between 4 and 10, I think it's reasonable to administer 1 to 2.5 milligrams vitamin K by mouth or 0.5 milligrams to 3 milligrams IV, depending on how high the INR is and how quickly reversal is needed. However, if the patient's INR is 10 and they're having massive bleeding, consult your ENT immediately and administer 10 milligrams vitamin K by slow intravenous infusion over 20 to 60 minutes. Other options you could consider is unactivated prothrombin complex concentrate, also known as Concentra. Now, let's talk about the disposition of these posterior bleeds. Most of your posterior bleeds, especially those with small amounts of active bleeding, will need to be admitted to a med-surg telemetry bed with cardiac monitoring and have their INR slowly corrected. Now, that pretty much covers everything you need to know about epistaxis. Quickly, let's go over the main points rapid fire. Epistaxis is a common complaint that occurs in up to 60% of the general population, so no matter what field of medicine you're in, you're likely to run across these patients on numerous occasions. Epistaxis has a bimodal age distribution, with most cases occurring before age 10 and then peaking in occurrence once more in patients 45 to 65 years of age. Epistaxis can be broken down into anterior and posterior bleeds. Anterior bleeds make up the majority of cases and account for about 90%. The most common origin of anterior bleeds occur in the Kisselbox plexus. 3 primary blood vessels anastomosis into this region and are as follows: the septal branch of the anterior ethmoid artery, the lateral branch of the spinopalatine artery, and the septal branch of the facial artery. While posterior nosebleeds most commonly arise from 2 vessels and are from the posterior lateral branches of the spinopalatine artery, or they may also arise from the internal carotid artery. The most common cause of anterior nosebleeds commonly result from mucosal trauma or irritation. You can remember these causes by the mnemonic forward, FORWARD, facial trauma, oral anticoagulation, repetitive chronic excoriations, wetness or lack of, such as a low moisture environment, arterial mucosal hyperemia, retained foreign body, and digital trauma from nose picking. Anterior and posterior causes can also be caused by numerous other etiologies. You can remember these causes by the mnemonic epistaxis, where E stands for ETOH or alcohol abuse, P stands for platelet dysfunction, I stands for intranasal corticosteroids, S stands for suspect other diseases such as Osler-Weber-Rendu disease, T stands for tumors, A stands for aneurysms, and X stands for factor 10A inhibitors. I stands for increased blood pressure, although this association is controversial, and S stands for systolic or diastolic congestive heart failure. As with all patients, take a look at the triage note and review the vital signs. Once you enter the room, your initial evaluation of the patient should focus on the ABCs of emergency medicine, making sure they're protecting their airway, speaking in full sentences, and are cardiovascularly stable. In these patients, make sure to note when their bleeding occurred, frequency, duration, and severity of blood loss. For example, is this an isolated episode, or have they been having multiple over the past days or weeks? Ask them about any associated symptoms like URIs or allergies. Take a good past medical history, nasal surgical history, family history of bleeding disorders, and social history for cocaine abuse. Next, you're going to want to do a detailed nasal exam. Pre-treat them with some nasal anesthesia before doing the nasal exam. Adequate anesthesia can be obtained with numerous different medications and methods, such as cotton balls soaked in 2% lidocaine without epi, or 1% lidocaine with epi. Initial treatment in all patients should begin with direct pressure for 10 to 15 minutes in vasoconstrictors. Many times these simple measures will stop the bleeding before you even enter the room. If the bleeding has stopped and you cannot identify the source of bleeding, simply monitor the patient in the ED for 30 to 60 minutes. If they're not having a rebleed, discharge them home with a prescription of Bactroban ointment to apply to the nasal mucosa 3 times a day for 3 days. However, what if in these patients you identify a source of bleeding and they're still slightly bleeding a little bit? Now you're going to need to cauterize the vessel with silver nitrate. After cauterization, monitor these patients for 30 to 60 minutes, making sure they don't rebleed, and then send them home with a prescription of Bactroban to use for 3 times a day for 3 days. Management for the patient who has an anterior bleed despite direct pressure, Afrin, and silver nitrate who has a rebleed can be achieved with a Mercell tampon ribbon gauze packing or nasal balloon catheter. Monitor the patient for 30 to 60 minutes, and if hemostasis is achieved, give these patients follow-up with ENT in 24 to 48 hours. Give them strict follow-up precautions to represent back to the ED if bleeding reoccurs and cannot be stopped with simple direct pressure. In the patient who, despite direct pressure, vasoconstrictors, and maybe even cauterization, continues to bleed and you're concerned for a posterior bleed, you can use either the Rapid Rhino, a 10 to 14 French Foley catheter, or balloon catheter such as the Epistat. If the bleeding has stopped and they're not hypoxic, send them home with the same follow-up precautions as before. In those patients who, despite direct pressure, vasoconstrictors, cauterization, and good posterior packing, who are on an oral anticoagulation, yet continue to have bright red blood seen in the posterior pharynx or oozing of blood from the anterior nose, you need to order blood work. Order some basic anticoagulation profiles including PT, PTT, and INR. You'll also want to add in a CBC and CMP to look at their hemoglobin, hematocrit, and liver function. In addition, if your patient presents hypotensive, altered, with signs of poor perfusion, order a type and cross early because they may need a blood transfusion later. So in these patients, you now have a couple of options. You can pack the contralateral nair with your posterior packing of choice. This will provide a counterforce to help provide hemostasis. But before you do this, I think it's reasonable to call your ENT and discuss the patient first. Depending on the severity of the bleeding, he may want to take the patient to the OR and cauterize the vessel or place his packing of choice. You will want to stop all anticoagulation medications and correct supertherapeutic INRs caused by warfarin. However, keep in mind that potential consequences of correcting the INR too rapidly are below their ideal range. Once you decide on anticoagulation, unfortunately there are no great studies with strict dosing protocols on the amounts of anticoagulation that should be given. You can consider giving IV or PO vitamin K in your patients with mild to moderate bleeding despite packing. If the patient's INR is between 4 and 10, I think it's reasonable to administer 1 to 2.5 milligrams vitamin K by mouth or 0.5 milligrams to 3 milligrams IV depending on how high the INR is and how quickly reversal is needed. Most of your posterior bleeds, especially those with small amounts of active bleeding, will need to be admitted to a med-surg telemetry bed with cardiac monitoring and have their INR slowly corrected. Well, that covers everything you need to know on epistaxis. If you guys have any questions or have any other management styles that you find more effective, please do not hesitate to email me at gray@physicianassistantboards.com. That's GRAY at physicianassistantboards.com. Until next time.